Great. So hi, everyone. Happy New Year, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thank you for joining us today. This is going to be a really great hour. We're still waiting for some people to join in, so we'll go through some housekeeping notes and then get started on the presentation. So I'm Ellen Taylor, Vice President for Research at the Center for Health Design and your host for today. And like I said, we'll just go through some housekeeping details to get everything started. First off, I hope you all had an opportunity to download the paper that we're talking about today. We'd really like to thank the Health Environments Research and Design Journal, the HERD Journal, for providing complimentary access to the articles that we review as part of this journal club. And if you haven't done so already, think about subscribing to HERD. There's a discount code for attendees. You can get 20% off the subscription using code HERD20. For those of you who are interested in AIA credits or EDAC credits, or you need a certification form, a certificate of completion, all of that information will be available in the chat window at the beginning and at the end of the session. In order to earn the credit, you need to complete the appropriate forms. So there's a few different forms to earn the EDAC credit. Make sure you keep that verification form for your own records, and then you'll self-submit the credit to Measure Learning at the time of your EDAC renewal. For AIA credit, fill out the verification form and purchase a CEU management fee for $12 in the center store, and then email that to Catherine Anchetta, and her email is listed on the form. To get a certificate of completion, fill out the request form via the WUFU link located in the chat window and purchase a CEU management fee for $12 in the center store. So this is really about you guys today, as well as our author. The EBD journal clubs are really intended to be interactive. Usually we have a short presentation followed by a more lengthy discussion. Today we're going to break it up a little. So it's going to be a little bit more of a continuous Q&A format with questions for me and all of you. Anytime you have a question, just type it into the Q&A window, and that's accessed from the bottom of your screen where the yellow arrow is pointing on screen. But if you're on a mobile device or some other platform, it might be in a different location. It might be at the top. So once you ask your questions, we'll figure out where it fits in. If it's relevant to what we're talking about at the time, we'll just insert it there, but we'll have Q&A at the end of the presentation as well. So as I said, we feel that these journal clubs are a little bit different, much more interactive, and we really want to engage the healthcare design community in a dialogue about important research to help us better understand the links between the built environment and health-related outcomes. We really want to give you the opportunity to be able to talk to the authors themselves and then help make that leap into application or into other research projects. So today, now we get to the meat of things. I am really excited. It is a pleasure and privilege to introduce you to Dr. Andrew M. Ibrahim, the author of the article that we're discussing today. Dr. Ibrahim is the Maud T. Lane Research Professor of Surgery, Architecture and Urban Planning at the University of Michigan, where he also serves as the Vice Chair of the Department for Surgery. He previously, for 6 years, was a Senior Principal and Chief Medical Officer at the global design and architecture firm HOK. He completed his undergraduate and medical degrees, both with honors at Case Western Reserve University, with a year of coursework at the University College London and the Bartlett School of Architecture. But because Dr. Ibrahim has such a unique perspective, I'm actually going to let him tell you a little bit more about himself. So Dr. Ibrahim, thank you for being with us today, and you can take it from here.
Awesome. Thanks so much, Ellen, and thanks to the center for this opportunity. I'm so thrilled that this many people care about risk adjustment and clinical outcomes, because it's actually super important and could fundamentally change the way we think about evidence. As Ellen alluded to, my story is a little unusual, so maybe I'll just tell you about my typical week. I'm a board certified general surgeon, so I'm in the OR every Monday, clinic every Tuesday, and every 5th week I'm on call for whatever comes in as an emergency. I've been fortunate to train and operate at some pretty great places and gotten to see a lot of our hospitals around the country. I'm a formally trained health services researcher. I've done my postgraduate training in econometrics and healthcare measurement. And I run a research group at Michigan called the Center for Healthcare Outcomes and Policy. We're a big group and we're busy. We just put out our annual report, over 500 papers in a year, about $35 million in active funding. And over 50 government and federal agencies have cited our work when they make their policies. So we're pretty comfortable with doing rigorous work that hopefully we know goes to have impact on the way we deliver healthcare. And before I did all that, I studied architecture. So I trained at the Bartlett for a year and did the foundation coursework there. Spent 6 great years at HOK as a senior principal and got to work on all kinds of projects. And I still get to do it every spring. I get to run a studio or help run a studio. This spring is going to be in generative design and augmented reality. And I'm excited that I still get to work with the students and keep that work up. So how does that all come together? My work usually comes together at 3 scales. The first is hospital design, and I'll talk about that in this research paper today. But just for additional context, I also do a lot of work thinking about hospital networks and regional delivery of care and what happens to a healthcare system after a merger and how do you use those accumulated assets to optimize delivery. Then finally, health in neighborhoods. And when someone has a bad outcome in the hospital, how much of it is due to the quality of care in the hospital and how much of it is actually the neighborhood they came from and how do those two things interact? So underscoring all of that, I have this belief that I've had for years of what I call health in all design, that everything we design and create can measurably improve health. And that's the rub of the article today, which is measurably. How do you actually measure the things that we think are important? And how do some of the different models that we commonly use potentially very much skew our results? So this is the article, and I'm going to go through the study, and my goal, hopefully by the end of the hour, are fourfold. One is to tell you something about how we compare pain medications. There's a lot of different things you can prescribe for pain. And so if patients are all being prescribed different medicines, how do you standardize that? How do you make that normative to make the comparisons? 2, I want to give you a little 101 on risk adjustment. It's a huge loaded topic, but it's a way that we commonly use in healthcare to make comparisons fair. And and it's what we used in this article. And I kind of want to show you what some of these models look like and help you understand what they're doing. This hopefully makes you more critical in methods. I'm not going to put you through formulas or make you write out any algebra, but I do want you to feel more comfortable with being more critical when you read some of these research papers, especially with clinical data, so you can make a real good judgment about whether it's worth influencing your practice. And then finally, what I'm going to describe to you is a natural experiment, and I'll give you an example of it. But my hope is to, by the end of the hour, the next time you walk through one of your buildings or facilities, you may be able to recognize an opportunity for a natural experiment and think like, oh, there actually is a great way that we could study this phenomenon that I've walked through every day for the number of years.
So, Andrew, I think you are truly a unicorn. Maybe not quite a unicorn, but pretty darn close. So I really appreciate that you're sharing this very interesting perspective that you have coming with a background in both design and medicine. So everybody had access to the paper. I hope everybody had a chance to read it, but we did have some last minute signups as well. So maybe you can just walk us through the study.
Yeah, I'm happy to. So this is the hospital where I work. This is Michigan Medicine. This happens to be our floor where we have a lot of surgical patients. And unfortunately, once you know as much as I do, you never quite walk through the floor the same way, and you immediately start to code all the design features. So this was my natural instinct when I started working here and started doing it. And there's some interesting quirks about some of the things we do in our building. You may be asking, geez, Andrew, why are you walking in the middle of the basement in this random corner? Well, it turns out we have a whole patient ward there. This is an overnight stay unit where we send a lot of our thyroid patients to stay overnight. The rooms are just separated by curtains. And when I round, I'm always going through that hallway. But I also get to walk here. So this is the 12th floor of our newest building, and it overlooks our arboretum. It's almost incredible. Even in the winter, which is the middle photo, like I still want to be in that building to look out that window. And it turns out this is a whole bank of patient rooms who also underwent the same procedure who stay in that room. We don't have enough space to put all our patients from that procedure in the same exact area of the hospital. So they end up getting split kind of randomly between these two groups. So thyroid surgery is an operation we do a lot of here at this university. And whether you do a half thyroid or total thyroid, it's the same incision and almost the same length of operation. And as I kind of alluded to, about half the patients end up in these private rooms that overlook the Arboretum with a view, and half are in the basement in a ward with no windows. So my natural instinct is to think like, well, geez, how does recovery differ? Like, I think I know my preference if I had to pick which room I wanted to stay. And obviously, there's a lot of landmark work, including Ulrich's work, now almost 3 decades old, that this may affect how much pain medicine you need. And so that was kind of my initial thought, like, what if I could just compare the pain medicine between these two groups? So we took the patient room that they were assigned to and where they stayed for the hospital stay and linked it into our clinical data. We have an infrastructure here where we have access to about 4 million patient records and their encounters in the hospital, and it's time-stamped every time they move throughout the hospital, so you know exactly where they were. One of the challenges of doing this is people get prescribed different pain medicine. So how would you start to compare the different ways that we prescribe pain medicine for patients? The standard nomenclature is morphine mill equivalents. And I'll show you a little bit about how you actually get to that to sort of standardize the way we use these medicines. For those of you who read the article, this will look familiar. This is from table 1 in the article, and oxycodone and hydrocodone sound very similar. They are in fact similar medicines, but they actually have different amounts of narcotic in them. And so if you just were comparing the number of pills and said, geez, I want to keep the dose the same, and there's 1 milligram of oxycodone and 1 of hydrocodone, you'd actually be comparing very different pain medications. So the standard convention in our practice is to convert all of these to morphine mill equivalents. And you can do this for any medication, any narcotic medication, including IV medications that can all convert to a standardized drug.
So Andrew, can I pause there for just a second? Because you had said this is a standard procedure that is done many, many times at your university, and it's the same surgical team. But with the 2 units, do the nurses rotate between those units, or are they assigned to the basement unit or the unit with the rooms with a view?
Yeah, great question. There are core nursing units that are by location. So the basement unit has its own nursing unit, and the private room has their own nursing unit. Interestingly, just because of the way nursing staffages have worked out, they tend to overlap a lot more, and nurses tend to move around, especially across surgical wards. So I'd maybe say up to a quarter or a third probably overlap, but probably the majority are specific to the unit. One limitation of this study is we didn't track specific nurses and their whether or not it was a certain nurse and that's why patients got more pain medicine or not. We potentially have the data to do that. We didn't do that in this particular study. So that's a great point to point out. But otherwise, the patients had the same surgeons, the same care teams in terms of residents, and in fact, the same order sets. So we try to standardize most things here. So the same default orders for what medicines are available are generally the same for all of these patients.
Okay, and then in the paper, you also, and it shows in the table here, so there was 2 scripts, hydrocodone or oxycodone, and you found that there were actually differences in what was prescribed between the 2 units. So do you have any comments on that?
Yeah, there's probably a little clinical context for that. So hydrocodone is typically it's oxycodone with Tylenol. And so if anybody has any limitations about why they could take Tylenol or couldn't, often because of like an underlying liver disease, then they do not get hydrocodone, they'd get oxycodone. So you could separate the two. In addition, if your pain was not well controlled with hydrocodone, you couldn't keep giving it because the Tylenol has a daily dosage limit. So then you would want to switch over to oxycodone. So part of it has to do with if there's reasons why they can't take one or the other.
Okay.
Great. Go ahead. Oh,
No, so you were also talking a lot about pain and you referenced the Roger Ulrich study. So I remember it was, I think, on the 25th anniversary of the study, which you had mentioned 30 years. It's amazing that it's been that long.
yeah.
Crazy. But I remember that Dr. Ulrich was saying at the time that measuring pain is pretty controversial within medicine. So I'm just curious, has that changed over time? And especially with, some of the things that we've seen with pain medication the past few years, where do we stand from a clinical perspective on that
Yeah.
whole issue
I
about
will
researching pain?
I will just date myself and say that when I started my surgical training, we had paper charts and paper scripts. And for a procedure like this, like I remember we used to sit in the team room and you would just write out 35 of oxycodone for every patient, and you just have them ready in your pocket for rounds. And when they went home, we'd send people home with 30 or 40 pills of narcotics. We now know that most patients don't need more than a handful. And our default now is to only prescribe them a handful. So there's definitely been a big momentum shift. And actually, a lot of it is in office, it's just down the hall from mine to reduce the amount of narcotics that we use after surgery. And so that brings up actually an interesting methodologic question. If you have this background force, such as everyone in the institution is trying to prescribe less and less narcotic pain medication, how do you account for that in your study? That'll come up in our regression model, because if historically the majority of patients were in the basement and now they're in the 12th floor and kind of vice versa, if you just compared the two groups, you might be totally skewed by this background trend. So I'll bring that up again in a little bit, but we definitely are prescribing far less pain medicine than we had previously. I love this question in the chat from Shelly. How does it decided where a patient goes after surgery? That's what I want to know, because I want to make sure I end up in the 12th floor. It is largely just based on what's available when the patient comes out of surgery. And so we start with usually the one unit until it's full, and then go to the next one. So there isn't a particular specific assignment that would point you towards one or the other, just what's available when you come out of the OR. Good
So
question.
do you want to take any of the other questions or wait
Oh,
until
yeah.
the
No, I
next
see more.
section of the presentation? I think one of them might be maybe something we can take at the end, but take a look and see if you want to tackle any of them now.
Oh, does the dosage different? Well, hold on to that thought, because we'll find out. We'll talk
Okay.
in a minute about does the dosage differ. All right.
Okay.
So here was, if we standardize to morphine mill equivalents and you just looked at it unadjusted, it appears that the patients who are in the private rooms of the view are using more pain medication than those who are in the ward downstairs. So let me pause there and maybe like leave that up to the group. Do you think that's like a fair comparison? If I just showed you these numbers, this is just averaged across all the patients who are in one place versus the other, and it looks like more pain medicine above.
So in the chat box, if you can all just start typing in fair, unfair, keyword unadjusted. Thank you.
Roz all over it. I love the unfairness. Good. That means everybody wants to stay tuned for how we're going to make this more fair. Wow. There's a lot of strong feelings about unfair. I love that.
Not that we didn't bias that in just a little bit.
So we do need to risk adjust our model, right? Like there may be multiple reasons why somebody may need more or less pain medicine, even if you put them through the same exact operation and the same incision and the same postoperative protocols, there still may be differences. So now gets the interesting part. So I won't tell you what the variable is. This will be your next question. I will tell you that this is now risk adjusted, is a logistic regression model. And the only thing I put in the model is a single variable. So try to guess in the chat, since we have a pretty engaged group who feels strongly about fairness. I love it. What was risk adjusted for that all of a sudden made this an even comparison. I see age and gender. And I'll tell you, age and gender are not it. So you have to keep guessing. Although those are good guesses and those do come back later. Comorbidities, weight, good
Lots of
question.
weights.
But no, these are great questions. I love it because clearly a lot of you have mental models in your mind about what are the things that you think contribute to someone's pain needs after surgery. I'm scrolling. I don't think I've seen the right answer yet. This is amazing. And I will just say, this one was actually a blind spot in our own group that we didn't put in our model until we talked to the person down the hall who studies opioids for a living. And she asked a very simple question. She goes, do you know if they've been on opioids ever before? So opioids are a medication where you can build up a tolerance to. So it turned out when we just looked in the previous year, was the patient ever prescribed tolerance? Nice, Tripty. Was the patient ever prescribed a narcotic pain medication? And we just put that into our model to say, we want to account for that. All of a sudden, the comparison becomes even. Now, many of you mentioned age and gender, and I didn't bake that, but that actually is the third comparison. If you then add age, gender, and opioid history into the model, it flips the other way. Now, all of a sudden, it looks like patients in the ward downstairs are getting more pain medication. Fascinating. Those are very simple models. One had one variable, one had three. And then compared to the unadjusted, we actually totally flipped the results. Is anybody like uncomfortable? It makes me uncomfortable. This is someone who studies, good question, Thane. They were statistically significant. I just didn't put it here, but it's in the table in the article. But that's a great question. Ooh, I love Sarayu. Sarayu just brought up this great point that Upali Nanda, one of my co-authors on this paper, brought up. What are some reasons why people in a ward may have less pain requirements than those in a private room? And Sarayu brought up this great point. In the basement ward, they have an opportunity to talk to each other. So there has been other literature that's described that actually distraction by having a roommate or being in a place with multiple people may actually correlate with the amount of pain medicine that you use. All of a sudden, knowing if our design strategies work or don't work is getting a little muddier, but everyone in this chat's like on the right page. Like, we need to think about these other mechanisms that may moderate this effect. So you may ask, what should go into your model for risk adjusting? I chose three things on that previous slide, largely to be illustrative, but let me give you a little more context from the econometric land. And there's probably two strategies that people typically apply. One is a very empiric model. So this is sort of a snapshot of table 1 from the manuscript that's really kind of comparing the characteristics of the patients who are in the single room wards versus the multi-bed wards. And you might notice just on the second line, people in the single room wards on average were 10 years younger. So you may just say, that's statistically significant with the p-value. So I want to risk adjust for that. So there are many people who will run their table 1 data, and based on that, will use anything that's significant in table 1, they will put into their risk adjustment model. So that's like one approach that's kind of objective and reproducible. Does anyone have any thoughts about a different approach you might take if you're not just, because the problem is when these data sets get so big, everything becomes significant. You can put everything in your model because everything will be significant. So if you wanted to be a little more judicious than just whatever's significant in table 1, any thoughts from the chat? What are some other ways you could start to sort what should be in your model? Ooh, matched pairs. Love that. Windows or not. All right. All right. These are a lot of good variables that people are posting. And what everyone's kind of getting at is they have some conceptual model of how they think patient's environment or their care is going to influence the family support, the amount of pain medicine they need. So let me show you here. This is a conceptual model from a different paper, unrelated, that I've written about who gets elective surgery versus emergency surgery. And in my kind of experience being in this work and the literature I've read, I know that if you don't have insurance coverage, a primary care referral, and an available surgeon, it's very hard to get elective surgery. But if you have all those three things, you're much more likely. And if you don't have those things, you probably will present as an emergency. All that to say, you'll start building these conceptual models to kind of understand, like, most of you intuited age, gender, and opioid history without seeing table one. So you may end up, what most people do is use some combination of these to say, here's some empiric things that we see are very different. And here are some conceptual things that I just think are really important because I have other research in this space. I have other content expertise that'll help do it. Wow, multicollinearity. Thanks, Renee. I didn't know we are going to get into variance inflation factors here, but this is good. So
we have some pretty in-depth research geeks on this call, so this is
I love
awesome.
it. This makes me very happy. So Renee brought up this interesting question of multicollinearity, and I'll unpack that for a little bit because it's important. So what if it's the case that one of these variables that we think is important, such as age, is also collinear with something else? So for example, age could be very collinear with your insurance type. Younger people tend to be on private insurance. And so you may, if you put all those things in your model and they're all kind of reinforcing the same thing, you may actually create like an overfit model because you are putting too many variables that are telling you the same thing. So that's multicollinearity. So one way to test for that or to sniff it out is to look for variance inflation factors. And if, depending on your threshold cutoff, if they're too high, then your variables are too collinear and you want to parse out your model. So cool. I love it. All right, Renee, hold tight because there's more geeking coming up. So you guys will be in for it. So not to coax you into reading a second article, but Mitch Mead, who's the first author of the paper that was assigned for today, went to architecture school and then unfortunately met me, worked with me for a couple of years, and now he's in medical school. But he wrote this great article for the Journal of Hospital Medicine that's also open source and free online to read, where he basically walked through other different methodology to risk adjust separate from this logistic regression. So we could geek out about all of these, but I just wanted to give you a flavor of some of them so that when you're reading some of these studies, you at least have something to look for to recognize, to say all right, they said they did propensity matching. I don't know all the details of propensity matching, but at least it gives me something to say all right, they're trying to accommodate for the differences between the groups. And that's valuable. So let me pause there before I go to the next slide. If you had to guess in the group, and this is work that we've been doing now, we've started to go through a lot of the built environment research that we've had for the last 2 decades, and specifically pulled out papers that use clinical outcomes, things that we measure clinically all the time, to measure the effect of the built environment. What % of papers do you think use any kind of risk adjustment? Doesn't have to be logistic regression, it could be any kind of strategy to accommodate? None of the papers, some of the papers, all of the papers, all the papers in the last 10 years, maybe. Any guesses from the group about what percent of papers have about appropriate risk adjustment?
We've already got a big range just from the few that have been entered in so far. And while people are putting their guesses in, I'll ask a quick question. So it seems like research in all fields has been evolving. So in terms of how often risk adjustment has been conducted just in the clinical world, you mentioned, maybe it's the past 10 years, and you were saying you looked at papers in the past 20. Has that even changed in medicine over time?
Absolutely. One of the phenomenon of medicine is we just measure everything, for better or for worse. We index and measure all kinds of stuff, and we have so much data, more than we know what to do with. And so as a result, we used to just run all kinds of things, and we've gotten much more thoughtful and judicious about, or much more thoughtful and comprehensive, I would say, about how we risk adjust. I think if you read medical papers from 30 years ago, they probably don't include much or any risk adjustment, or if they do, they're missing the wrong variables. One of the caveats of something like a logistic regression, which is the example that we're using kind of in this paper, is you can only put it in your model if you have that data. So if you don't have data about how much daylight did they get during the day, or did they take opioids before, if you don't have that data, you can't put it in your model. So sometimes you may conceptually develop these ideas of what matters, but not have that data available. And I'd say that's probably still true of a lot of papers in medicine written now. So it's good to be thoughtful about not just did they do it, not do it, but what's kind of actually in the model. All right, some of you, go ahead.
No, I was just going to say, it's an interesting point in the clinical literature. I know that, sometimes, especially clinicians, not to say anything against your profession, Dr. Ibrahim, but a lot of times people will sort of, let's say, diminish the role of the built environment. And certainly the built environment isn't the silver bullet solution. But for all of the clinical research that's been done that doesn't take into account the amount of daylight that somebody had or these other built environment types issues, one could always say that there's some limitations that haven't been recognized on the clinical side as well. So
Yeah.
I think everybody has weighed in. Most people are way on the low end of the scale, 25% or less.
You guys are harsh. This is a harsh crowd, but this is what we want. We want critical people taking
So
this
I'm
on.
I'm feeling much better about your real results
So,
here.
so we have this under review right now, but about half the papers. So not bad, not good. When you're looking at evidence, you kind of want to think like, gosh, what half was I reading, and was this on my radar? I think in this crowd there may be a lot of people who are very thoughtful and read through the methods and dig into it. I'll tell you, I've been in many rooms with clients who I think are pretty sophisticated, who bring research to the table and don't haven't caught some of these details about the quality of the data. And certainly in some firms, that's also true. So all of us have room for improvement on this, without question.
So I want to
Yeah.
pause again, and you just raised another interesting point. So I think that there is sometimes a tendency to read the abstract and not necessarily read the entirety of the paper. And sometimes that's a logistic issue where it's behind the paywall and you just can't get the paper. But there are so many things that are in the paper that aren't represented in the abstract. And sometimes that is really important information because the abstract has to be so simplified that there might be some bias in how the abstract is written to try and convey the main point. But those details are also so important. So you've indicated that we should be cautious when we're reading papers like this. Are there times when risk adjustment might be less critical in the topic being studied, or times where it's maybe more critical?
I love it. Great question. Theoretically, if you have a randomized control trial you theoretically should not need to risk adjust because the differences between the groups theoretically should randomly go here and randomly go here, which is partially why the medical literature has put so much emphasis on randomized trials, because whether it's measured or not measured, you theoretically have put it evenly within both groups. If any of you super want to nerd out, I can send you a whole book chapter on quality measurement that I've written in the past. But one of the things that's interesting is if you think about the cohort you want to study, some groups of patients tend to be more alike just by selecting for why they're in the hospital. So for example, if you look at patients who have open heart surgery to replace a heart valve, that's like a pretty specific group. And in order to get the surgery, they tend to have a lot of the same risk factors, and they tend to have a lot of the same indications for surgery. So if you did the table 1 data on those patients, they'd probably be pretty similar no matter how you split them up. So one strategy, if you are trying to say, I don't know that we can really risk adjust this cohort, we don't have all the quite data we want, you can try to select a cohort where you think they're fairly similar, either based on why they're in the hospital or the way they got triaged, et cetera. Not perfect, but the textbook answer would be only in a randomized trial, you don't need to. But in real world pragmatic, if there are narrow reasons why you're in the study, you may not have to do as much risk adjustment.
So I think we talked a little bit about this as well in terms of what's happened in the more recent years relative to opioids. And, you had mentioned you used to give out 40 and now you just give out a handful. So given that vigilance, is there a specified time frame that people should be aware of when we're specifically looking at papers that talk about pain medication? Because to your point, a paper published 30 years ago probably has a very different approach to pain medication than what we'd find in a paper published this year.
Yeah, I'd say the opioid literature has probably all changed dramatically. I think in the last, I'm trying to think of an exact date. It's definitely in the last 10 years, because that's how long ago I finished med school more than 10 years ago. So it's less than it's since I graduated medical school. So it's less than 10 years that should be in mind. So interestingly, for your logistic regression, if you know that over the last 10 years, there's been a progressive decline in how much we prescribe, one thing you can do is put the year of the operation into your model as another risk adjusted variable to say, like, if we just took into account kind of what the norms were in 2015 versus 2020 or whatever, we could start to tease out some of those differences. So you're right, it's totally a different environment than we used to be in. And in fact, I think some would say we've potentially gone too far in being too judicious in pain medicine, but separate conversation.
Yep. And you and I can have that separate conversation shortly. So it's so fascinating. And I think you're bringing up some really interesting points that statistics is not a black and white issue. There is an art to understanding statistics, and there's an art to building models. And then we can maybe talk a little bit more about those models as we work through some of these other questions. But given everything that you've just shared with us so far, there was a recent study by Jafari and colleagues that looked at views and daylight, not just views, but also daylight, which gets to one of the questions that we may address coming up. It was also like this wonderfully neatly packaged natural experiment. And that had a pretty diverse team in terms of getting the organizational clinical data, having a statistician on board to really be able to look at some of that. So what is the best way to pull together a group of people, and where do you find some of the people, like who should really be on your team to get this work done?
I love it. These all of these methods have gotten quite sophisticated, to the point where even like the PhD economist or epidemiologist have their narrow slivers within it. I think if you are fortunate, if you're in the firm side and you have a client that is tied to like a school of public health is an outstanding place to start. The other kind of buzzword is a health services researcher, and we tend to be all around. And I think most people who are formally trained in the research are pretty comfortable telling you whether or not they know how to use the method or not. But in addition to knowing like the mechanics of the math, you want someone who's like on the ground, kind of experientially firsthand the work. Either they've worked in one of these wards, they've worked in one of these hospitals, they've been responsible for prescribing some of these medicines. You want people who also have firsthand knowledge to help you build out your model. So I'd say like a content expert, which may be real lived, as well as a methods expert. And I think with any of the design work, I learned so much on this specific paper by doing this with Upali, because she's designed so many of these spaces. She said, well, let me tell you all the considerations when we design different wards like this and the different trade-offs. And we had to figure out like how much of that we build into our model. Devil's advocate question. Can we go to this one next, Ellen? Is that okay?
Sure. Go
Why
ahead, read the question.
Why do the study at all? Asked Renee. I'm not suggesting it's not helpful, and I can think of several reasons why this would be a useful piece of evidence. But in this specific case study, how does light contribute to recovery? For a case like this, it's not obvious or common sense. Great question, Renee. So the point of the study was not to make a definitive statement about does pain medication change whether you have a private room or a ward. The primary goal of the study was almost to be illustrative that just using models that are very similar give you extremely different results. So in part, it was illustrative. The other reason we chose to do it is because these natural experiments happen in the hospital all the time. Like it just happens by chance in this example that this same group of patients are going to the 12th floor or the basement. But I think if we think about in our own hospital and environments, there may be subtler differences in how patients get moved throughout the building that might give us an opportunity to leverage those as natural experiments.
So there's definitely some other questions in here, and I continue to have questions too, but let's get some more from the audience as we work through here. I think there's an interesting question here. Of course, everybody is talking about AI these days, and you had mentioned that, augmented reality and some of these new technologies are going to be the focus of your studio coming up. But the question asked is, how might AI affect the quantity and types of variables to be calculated? Obviously, there's more computing power and more iterations that can be run with AI. So what do you think? Where are we headed?
Oh, I love it. No, it's a great question. I've totally gone down this AI rabbit hole, including in the design world. I mean, some of these Adobe plugins for AI, it's almost scary how fast you can iterate the stuff. And my interest in AI is far less about it being able to like do the work for us. But I think what you hit on, Ellen, is they've unlocked some pretty impressive computing power. And it's a double-edged sword because now the computing power that we have that AI is basically enabled, you can put 1 million things into your variable. You can put 10 million things in the variable. And so you'll start hearing about machine learning algorithms. Part of what these machine learning algorithms do is they take every possible data point, even remotely available, and then try to put that into the model and iteratively work through sequences to come out with an ideal model. You'll hear about lassoing is one of the ways it does that. I find that like a little unsettling in that like your models should be ideally grounded in a conceptual model that allows you to have some firm footing into why you're putting things in or not. And so I think the computing power is the biggest advantage, but it also comes with a double-edged sword that I think people may get a little carried away and put too much into the model and kind of lead themselves astray.
Yeah, I think there's a general challenge with generative AI that it sounds very convincing. And the challenge is you need to know quite a bit to understand when it's exaggerating or even hallucinating, to the extent that it even creates fake citations to support what it's telling you. So yeah, I think we all need to be aware of some of the challenges going forward. Just like you're saying, we have to be critical of how the research is done and how the analysis is done. I know many journals, and I know you're affiliated with a journal too, are starting to have authors attest, like, how did you use AI, and if so, how? Because there's not necessarily something wrong with using AI, but being transparent about how you used it is important as well. So there's some other questions here. There's a question on the subject of windows. I'm attending the session from a patient room that was built with a view to nature, but the patient can't see anything due to the bed rail blocking her view. So the only advantage to having the window in the room is to know whether it's light or dark outside, and the shade has been down for the entire stay. That variable is probably something that's never taken into consideration. Would that have impact?
Oh my gosh, I love the question because it demonstrates why like it'd be awesome to have someone from design or architecture like on your team. So if you were just going to ask the average health services researcher or physician, we would probably buy the argument of window, no window, but I don't think any of us would have had insight into the nuance of what was just described of like, yeah, but was it a meaningful window that they could actually access? So I think that wasn't measured in this specific study, but would be a great example of how a designer would actually probably weigh in and modify the model to say, it's not just a window. It depends on the railing and the height of the positioning of the bed, whether or not we think that window is going to have an effect. So I love that question because it demonstrates kind of everyone has a stake in helping build the right model.
Yeah, and again, I mentioned the Jafari paper, which did actually look at differences between view and daylight and rooms that didn't have a window. And there is an impact associated with daylight. If the shades are down, then I think it gets back to that question, like how much daylight? What's the dosage of daylight? So, still many things to uncover. So there's other questions here. Maybe we can scroll to the top and start working our way down again. So one of the first questions that was asked, and if you put your question in the chat box and didn't make it over to the Q&A box, just cut and paste that for us so that we can make sure that we address that when we have time. Based on the location of the units, the one with daylight views and one with no views, what was the data for patient satisfaction or patient recovery rates, staff retention and satisfaction, and patient family satisfaction?
Oh my gosh, Anuya, it's like you like planted me to tell this story. So in our hospital, and I think most hospitals, and I know Renee and a couple other people are hospital administrators, so they know this data. Patient satisfaction gets reported all the time, all the way down to the nursing unit. And a lot of that data comes from surveys that get sent to patients. And the industry standard around that is around a 20 to 30% response rate. If your satisfaction score dips 1%, like level 5 alarm bells go off, all hands on deck meeting. We have to figure out what happened. And I went to a patient experience officer and I said, do you know like what rooms the patients who filled the survey out came from? And they said, tell me more. And I said, is it possible that the reason you see differences month to month in satisfaction scores is just based on the 20 or 30% of patients who are filling it out stayed in different rooms, and their jaw kind of dropped? So we're in the process of actually trying to get our patient satisfaction data and try to tie that to rooms. But I am with you and share the hypothesis that it is likely that the room design will influence your patient satisfaction score. Alan, I don't know offhand, but do you know of recent papers that have looked at patient satisfaction scores based on room assignment? Or if anyone else does. I'm not sure that I know of a specific paper that targeted that specifically.
I know that there are papers about HCAP scores relative to noise. There may be some about satisfaction. I know there's another one that was published a couple of years ago about the relative newness of the facility and HCAP scores, which kind of gets to that because newer facilities tend to have, larger rooms and rooms with larger windows and views where possible. But the specific one, I'd have to go in and take a look. There's another question that's sort of related to that, sort of in a tangential way. Did you notice that those in the basement ward tended to mirror other patients' behavior when receiving pain medications? And is that something that was monitored?
Super interesting. I don't know offhand. However, all of the pain medicine that we tracked in our study is time stamped to when it's administered. So theoretically, we could look at rooms and see, did you just happen to get your pain medicine right after the person next to you got theirs? That's a little tricky because a lot of nurses do their PRNs almost like in rounds. And so there might be something there, but we could try to test that hypothesis to see, do you happen to get your pain medicine more if the person next to you just got theirs? Great question. We didn't monitor for that, but it's something we could dig into.
Always more to look at, right? The next research study. So there's another question here. Given that the room assignments were random, or one unit fills up and then you start moving to the next unit, the question is it the same price for the basement and the 12th room floor? And that I imagine is going to be different depending upon the country that you're in.
Yeah, I actually don't know. Theoretically, the way we charge for procedures is based on a procedural code. I know other hospitals do. Our particular hospital does not charge a supplement fee to get you like a bigger room or something. I do know hospitals that if you do pay a supplemental fee, you do get a private room or a window room. So that wasn't the case in our paper, but that would be a super important confounder that we'd have to take into account too, that if people were able to pay to get into different rooms, gosh, that tracks with a whole other line of things that are important. So wasn't the case here, but what a great concept to take into account.
Yeah, then you're really starting to get into the area of health equity and those who have and those who have not. So there's another question asked by Renee. You answered a prior question there. Is pain medication use a good proxy for recovery?
No. It's a good question. Because it would depend how you're going to measure recovery. I will say for a number of our procedures, we expect you to have decreasing pain within a couple days and off pain medicine. For all the operations I do, should be off pain medicine within a week or less. If you're still on pain medicine, it does raise my spidey sense that you may be having a complication or something may be going on that's causing you more pain. That may not always be true. There may just be people who need more time to recover. But I, at least clinically, use need for additional pain medicine as maybe a potential warning sign that the patient's not recovering appropriately. Certainly in surgery, when we watch people in the hospital, if their pain medicine goes down, down, down and shoots up, we start to investigate more if something's changed about their condition.
Okay, I think we have time for maybe one or two more questions, and then we need to do some wrap up. There's a question, these might be a little bit related. One is about the dosage difference with the basement ward versus the private room with window. And then there's another question, if there was higher opioid tolerance in the patients in the private rooms with windows, is there a reason that would have occurred? Was there another factor? I'm not sure if you have answers to that, but what are your thoughts?
I'd have to snoop and dig in and look back at it. I don't know offhand if I have an explanation for if there were differences about that.
And then
Good question.
Can you refresh us the time frame for the study?
These were all, I think, in the last 6 or 7 years. I forget the exact cutoff, but overlapped with the beginning of COVID and about 5 years before, I think.
Okay, and then there's any noise factors were taken into account?
Did not. Upali offered to give me her noise measuring equipment.
Her dosimeter, her app.
Yeah, but when we were writing this, we were still in like wave 2 of COVID. So we were reluctant to put extra people in the hospital if they didn't need to be there. But certainly a thing. We have noticed separate study that we're working on now that patients who are in rooms closer to the nursing unit, which tend to be a little bit louder, tend to get prescribed more sleep aids at night. And I like kind of buy the conceptual model there potentially, but we have to figure out all the risk adjustment and account for that stuff. But yeah, super important.
Yeah, you used a term earlier in our conversation, and I've heard it before from people that are reviewing research, nurses who are actually doing that for a project. And one of the comments is it has to pass the sniff test. Like
Yeah,
ultimately, it kind of has to make sense. Otherwise, are you really looking at the right thing or
that is
not?
a
So I think one more question, and this could be a little bit of a sticky one, and then I'm going to go into the housekeeping, and I may chime in on this one too. Would you caution practitioners against quoting or referring to the Ulrich study from now on?
I would say in general, I never really hang my hat on one study. If the findings are real and robust, we should be able to replicate them over and over. I think most of us at face value would accept that having a window view is probably helpful to your recovery. I think we probably just need to be more precise about one, what do we mean by recovery? And two, like what's the effect size? Like, is it likely that a window view is going to get you out of the hospital twice as fast as if you didn't have a window view? I probably don't buy that effect size. Might it help you maybe to a smaller magnitude? Sure. So I think the Ulrich study to me is conceptually correct. I think the magnitude of the effect is probably where we need the replicating studies to sort of better hone that in. And also open cholecystectomies, which is what he studied. We don't really do those anymore. We
Yeah,
now do 4 incisions this big and people go home the same day. So it's kind of interesting. It's like a different era and needs different ways to think about the problem.
yeah, and I'll chime in. I mean, there's been lots of different types of replications of that study about views of nature that are pretty consistent in the results. And the study that I referenced earlier in the CCU, which was a natural experiment, they did find that there was a reduction in length of stay associated with view and potentially daylight as well. So it's always important to keep up with what's going on. But to your point, it's interesting because the delivery of care has changed so much since 1984. So always good to get some replication in and make sure that we actually do know what we're talking about. So with that, I'm sorry that we didn't get to all of the questions, but we got to many of them. And Dr. Ibrahim, really want to thank you for being here with us today and sharing your expertise and really challenging us to think a little bit harder about some of the things that we're doing and if we're conducting research to make sure that we have the right people on our team. So I also want to thank the Health Environments Research and Design Journal again for providing free access to the article that we talked about today. Again, if you would like to subscribe, you can get a 20% discount by using the code HERD20. I'd also just encourage everybody to check out the Center for Health Design's event page to see what we have on the horizon. Right now, we have an EDAC risk-free offer that is ending soon. We have new strategies for evaluating patient room design features using mockups and simulations as a webinar coming up. And then we have the PDC Summit coming up in San Diego, which we're proud to be a part of for the first time this year. I'm also ask you to join us on January 25th for the Center's 4th annual workshop on design for aging. And this workshop will feature thought leaders who will share insights on the future direction of environments for people as they age. And if you're not an affiliate of the Center, I'd encourage you to think about becoming one. You can be part of a community of more than 6,000 professionals. We include member discounts on things like the EDAC exam and the study guides, webinars, and more. You're offered greater visibility within the industry. You can stay current on advances in evidence-based facility design. You can stay connected with a community of like-minded professionals, equip yourself with tools and resources, and you can show your support for the center and the work that we do. So if you'd like more information, feel free to contact Lynn Kenny, lkenny@healthdesign.org. And if you sign up by February 15th, you can join at a discounted rate. So I know there was another question earlier about the CEU verification. So again, those forms are in the chat box. And in order to get the credit, you'll need to fill out the form and either self-submit for EDAC or purchase a $12 processing fee from the center's store for AIA credit and a certificate of completion. So thank you again, Dr. Ibrahim, for sharing everything that you've been working on. This will be the end of our event today. We'll leave the webinar open for another 15 minutes or so that you can download the continuing education forms and slides from us in the chat box. Thanks for joining and have a great day.
Thanks, everyone.